Hello everyone, this is Mahesh. I am going to present a seminar on topic meningioma. Let's go into introduction. Meningioma is the most common of all intracranial neoplasms, or a third of all primary intracranial neoplasms, and female predominance is seen here, where female is to male ratio is 2:1. Peak occurrence is in the 6th to 7th decades. Around mean is 65 years. Although meningioma account for slightly less than 3% of primary brain tumors in children, meningioma still presents. It still represents the most common dura-based neoplasms in the age group. NF2 related meningiomas occurs at significantly younger age compared with the non-syndromic meningiomas. Symptoms related to size and tumor site. Less than 10% of meningiomas become symptomatic. Types: WHO grade 1, WHO grade 2, and WHO grade 1 is most common type and it is benign. WHO grade 2 is more aggressive clinical behavior and less favorable outcomes. The most aggressive form of meningioma, corresponding to WHO grade 3, is anaplastic malignant meningioma. Etiology: ionizing radiations is the only established risk factor. The dose related time interval to tumor development varies from 20 to 40 years. And NF2 mutations are detected in most meningiomas associated with type 2 neurofibroblasts. NF2 and are found in up to 60% of saprotic meningiomas. NF2 mutant meningiomas originate along the posterior or superior cerebral hemispheres, the posterior and lateral skull base, and the spinal cord. Non-NF2 meningiomas are usually benign and originate from the medial skull base and anterior cerebral hemispheres. Here you can see the meningioma locations. And now let's see size and number. Meningiomas vary widely in size. Most are small, less than 1 centimeter, and found incidentally. Some, especially those arising in the anterior fossa from the olfactory groove, may attain large size before causing symptoms. Here you can see the meningioma in cut section shows that attachment to the dura, relative dural thickenings. Imaging CT: round and lobulated, sharply demarcated extra-axial dura-based mass that buckles the cortex inward. 3/4 of the meningiomas are mildly to moderate hyperdense compared with cortex. 1/4 are isodense. Peritumoral vasogenic edema, seen as a confirmed hypodensity in the adjacent drain, is present in about 60% of all cases. CT: the vast majority of the meningioma enhance strongly and uniformly. 25% demonstrate calcification. Focal, globular, or more diffuse sand-like calcification occurs. Frank necrosis or hemorrhage is rare. CT: bone CT may show hyperostosis that varies from minimal to striking. A striking enlargement of an adjacent paranasal sinuses may occur with skull-based meningiomas. Bone involvement by meningioma occurs with both benign and malignant meningiomas and is not predictive of tumor grade. Here you can see the isodense left convexity mass that enhances uniformly. This is a classic meningioma which is WHO grade 1. Here you can see the right frontal mass left side and this is an incidental finding. MRA. MRA. T1. Meningiomas are typically ISO to hypointensive compared with cortex. T2. ISO to moderately hyperintensive compared with cortex. CSF vesicular cleft is seen as an hyperintensive rim interposed between the tumor and brain on T2. The number of flow voids representing displaced vessels are often seen within the cleft. Sometimes a sunburst pattern can be identified radiating towards the periphery of the mass. Here the sunburst pattern will be like radiating towards the periphery of the mass. And flare varies from ISO to hyperintensive, useful for depleting peritumoral edema seen in half of the patients. Peritumoral edema is related to the presence of plial blood wave supply and VGF expression, not tumor size or grade. Over 95% enhance strongly and homogeneously. Dural is seen in majority. It enhances more intensely and more uniformly than tumor itself. Dural is not pathogenic. DWI. Most meningiomas do not restrict on DWI. MRS. Alanine peak is sensitive. Glutamine peak at 2.1 to 2.6 ppm, and glutathione peak at 2.95 ppm. Maybe more specific potential markers. Perfusion MR helpful in distinguish TM from atypical and malignant meningiomas. High RCBV in the lesions or in the surrounding edema suggests a more aggressive tumor grade. Occasionally skull-based meningioma suggestion to paranasal sinuses cause massive enlargement of sinuses. A condition is known as pneumosinuses dilatans. And here you can see the picture which shows that adjacent dural thickenings, dural tail signs is common. You can see here, and sunburst of vessels where it moves peripheral to one side of the mass. Meningioma mimics. Here you can see commonly metastasis, lymphoma, less common granuloma, and rare but important that is IgG4 related diseases, dural venous sinus hemorrhagia, such things. And atypical meningioma, 10 to 15% of all meningiomas. Most atypical and malignant meningiomas arise from the calvaria. The skull base is relatively uncommon location for these more aggressive lesions. 50% of atypical meningiomas invade the adjacent brain, so no cleft is seen. Imaging in distinct borders and heterogeneous lesions. Frank bone invasion with osteosis is common, better seen in CT. Absence of CSF vesicular cleft, peritumoral edema. Constant enhancement is the strong but often quite heterogeneous. ACD is significantly lower in atypical and malignant meningiomas. Perfusion MRI may show elevated RCBV, especially in the peritumoral edema. Here you can see the clear cell type atypical meningiomas. And we have like anaplastic meningioma. Anaplastic meningioma is a rare case where we gonna see like 1 to 3% of meningioma. First we have seen that as like female predominance. Now anaplastic meningioma is the male predominance one. Imaging tried extracranial mass osteolysis, like mushrooming intracranial tumor. Here we can see the papillary meningioma grade 3. Thank you.